Hello and welcome to Part 2. So let us continue where we led off. In a 2020 study titled Fenbendazole Exhibits Anti-Tumor Activity Against Cervical Cancer, scientists demonstrated that in xenograft models, fenbendazole, given at 100 milligrams per kilogram, significantly suppressed tumor growth versus controls, without weight loss. Survival in fenbendazole groups was 100% versus 40% in cisplatin control versus 0% in untreated controls.
Mechanistically, fenbendazole induced G2 to M cell cycle arrest via upregulation of cyclin B1, phosphorylation of CDC25C to serine 198, downregulation of WEE1, and CDK1 phosphorylation, triggering apoptosis in both bulk cancer cells and cancer stem cells. The study highlighted that fenbendazole could target both therapy-resistant stem-like cancer cells and the main tumor cell population in cervical cancer.
A transcriptomic analysis in BMC Cancer, published in 2024, further supported that fenbendazole influences multiple gene expression networks. It increased pro-apoptotic genes. For example, it cleaved caspase-3, BAX, shifted metabolic and signaling pathways, and inhibited proliferation of ovarian cancer cells in vitro and in vivo. They demonstrated that use of a pan-caspase inhibitor, ZVAD-FMK, partially reversed fenbendazole-induced death, indicating a caspase-dependent apoptosis component.
In colorectal cancer models resistant to 5-fluorouracil, fenbendazole had greater efficacy than albendazole. It induced apoptosis, G2M arrest, ferroptosis-augmented apoptosis, and did so without requiring p53. However, a cautionary mouse study titled Unexpected Anti-Tumorigenic Effect of Fenbendazole when Combined with Vitamins found that fenbendazole alone did not slow tumor growth in lymphoma-bearing mice, but the combination of fenbendazole plus vitamins did. The authors emphasized that this drug alone had no detectable effect in that model, warning that confounding interactions could mislead interpretations.
Interesting. Addition of vitamins seems to have created more desired effect. Okay, so let's see a more recent case series entitled Fenbendazole as an Anti-Cancer Agent, a case series of self-administration, reports 3 human cancer patients who took fenbendazole off-label. 2 purported complete remissions and 1 near-complete remission. But the authors themselves caution that these are anecdotal, uncontrolled, and cannot clearly isolate fenbendazole's role as a standalone model.
So, what molecular hooks do ivermectin and fenbendazole use to affect cancer cells? This section dives deeper. Let's start with fenbendazole. First, the microtubule and tubulin binding. Fenbendazole belongs to benzimidazoles, which classically bind beta-tubulin and disrupt microtubule polymerization, interfering with cell division. This is similar in principle to how vinca alkaloids or taxanes act. In cancer cells, disrupting microtubules can lead to mitotic arrest and eventual cell death. Next, cell cycle arrest, G2/M phase. Many studies show fenbendazole upregulates cyclin B1, phosphorylated CDC25C, downregulates WEE1 and CDK1 phosphorylation, thereby enforcing a G2/M block. This stall in mitosis gives time for apoptotic signals to accumulate.
Next action, apoptosis via caspase activation. Fenbendazole increases cleaved caspase-3, BAX, and the BAX/BCL2 ratio in many models. Partial rescue with Z-VAD-FMK, a pan-caspase inhibitor, suggests caspase-dependent pathways are key, but there are more pathways it interacts with. Another one is metabolic reprogramming and stress pathways. Some studies suggest fenbendazole disrupts cancer cell metabolism, glucose, possibly glutamine pathways, though precise targets are not fully mapped. Transcriptomic data suggest modulation of signaling networks, oxidative stress, and energy balance. Finally, its targeting of cancer stem cells and resistant cells. In the cervical cancer model, FBZ apparently targeted both bulk tumor cells and therapy-resistant cancer stem cell populations, CSCs. In 5 FU-resistant colorectal models, fenbendazole worked independent of p53 status, making it attractive for resistant disease.
So yes, we can conclude that fenbendazole in models combines microtubule stress, mitotic arrest, induction of apoptosis, metabolic stress, and possibly effects on resistant subpopulations. This is exceptional action, and it is understandable why patients report extraordinary results as well as many remission or cure stories out there.
However, for science to fully integrate this drug into a protocol for cancer treatment, it has to follow a more stringent set of rules and parameters. But that is not to say that it does not work, or that patients who claim recovery are wrong. Join us on Patreon for Part 3 as we continue to discuss science behind these two emerging repurposed drugs. By becoming a member on Patreon, you will not only help support our work, but also enjoy access to content only available to our subscribers.